Now represents Dr. Hanan Hamed, inherited bleeding disorders in female and the role of rFV factor 8, factor 7.
Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank organizing committee for giving me the chance to be with you today. I'm not a gynecologist. I don't have that privilege. I am an internist and my subspecialty is clinical hematology. What I'm going to discuss now is some rare bleeding disorders in the field of OBGYN and their impact on the patient and in our practice. As Professor Saad said in his first presentation, most of the postpartum death is due to bleeding tendency. And this bleeding tendency sometimes is mildly noticed prior to a history of obstetrics or gynecological problem, or ignored due to many social things we know. So some people can bleed, but some people bleed more. And this bleeding could be due to platelet abnormality, either in number, which is thrombocytopenia, or in function, which is thrombocythemia, due to coagulation factor abnormalities like acquired things like hemophilia A, B, and von Willebrand factor, or acquired causes like liver disease. But there are a big cave, which I don't like to discuss now because it's full of very bad things and it is really life-threatening in bleeding, which is a subject by its own. This is one of my favorite structures for me, or I can't say cells, but I like them very much, which are the platelets. The platelets are not only for hemostasis, they are having plenty of functions for tissue repair, in inflammation, in malignancy, and even in thrombotic tendencies. So I do have a great admiration and respect for platelets. Platelets are having many receptors on their wall. Each one of these receptors are having a very specific function. One of these most important receptors is glycoprotein 2B3A, which are facilitating the connection and formation of fibrinogen and the interaction with von Willebrand factor to the endothelium, and they have a great impact in prevention of bleeding in patients with bleeding tendencies. The platelet plug formation goes into 3 steps: adhesion, aggregation, and secretion. And this is a very nice electron microscopy, how platelets are stuffing themselves like an army, preventing gush of blood from the crack in the peripheral vessel. Nothing teaches us better than a patient. And this is one of my patients I saw maybe 10 years ago. At that time, she was 26 years old, presented on her 2nd trimester for hematological consultation for a bleeding tendency. And she is recording menorrhagia since starting menarche. No family history of bleeding tendency, normal CBC, PT, and PTT, and pelvic abdominal ultrasonography showed no abnormality other than the obstetric ultrasonography. الحقيقة احنا عادة بنبص على عدد الصفائح وعلى الPT والPTT. But I do like the deserted or ignored lab tests, which could be simple and decisive for us. This patient has normal PT, PTT, normal platelet 1 and 61. She was type 1. So where is the issue? Where is the issue in this patient? She's a straightforward Glanzmann thrombocythemia. This patient is brought by her uncle because she is an orphan, and her mother is very, very يعني low class. أنا آسفة إني أقول اللفظ، بس هي كانت ست في منتهى البؤس والشقاء، والأم وعمها وعم البنت they brought her to consult for 17 years old. She's not educated, she's very poor, and they are trying or deciding to victimize her. This will abolish totally her chance to get married and to have a family and to have a normal life. So this is a tragedy due to a disease. Again, these are the receptors I told you you're aware of, glycoprotein 3A to B. This is Glanzmann, who described for the first time 1918 Glanzmann thrombasthenia. The disease is autosomal recessive disorder. The incidence in 1 in a million, so it's not that common. But again, because as Dr. Sarah said, we are having very high incidence of consanguinity. We can see cases up to 1 in even a quarter of a million with Glanzmann thrombasthenia. I weekly or even every other week diagnose a case of Glanzmann thrombasthenia. So they are there and they are diagnosed by both flow cytometry and genetic counseling. The genetics of Glanzmann thrombasthenia, we have identified the position of the gene on chromosome 17 and a combo of different flavors of genetic mutation, either substitution, insertion, deletion, or splicing abnormalities have been recorded in case of Glanzmann thrombasthenia. These are the positions of the two genes responsible for that, and these are the name of the two genes responsible for Glanzmann thrombasthenia. What about the clinical presentation? They look like any platelet abnormality. This is a bleeding of cutaneous and mucoid tissue bleeding subcutaneously or from a mucous membrane. They do not have platelet disorders. They do not have hemochromos at all. And as I said, these are the sites of bleeding. Intracranial hemorrhage, joint muscle bleeding are very uncommon, but anywhere could bleed. Like a lady could bleed from a gynecological reason or from her vagina due to uterine bleeding. She could bleed from her GIT. She could bleed from her nasopharynx. She could bleed from anywhere. To diagnose, as I said, everything is normal. Platelet count, PT, PTT, thrombin time, fibrinogen, all of that are normal in examining laboratory or common laboratory data. The only thing which is abnormal is starting from the forgotten bleeding time, then the flow cytometry with abnormal population of very much defect of CD41 and CD61. We have other congenital platelet abnormality or platelet thrombocythemia with different CDs decrease expression, but they are not the topic of our today's presentation. Are all Glanzmann thrombocythemia alike? They are 3 types, depending on the level of the clone of abnormal cells. If they are less than 5%, it's type 1, 5 to 20, type 2, more than 20, it is type 3. And these are type 1, 2, 3, according to flow cytometry. How to treat? When we are targeting treatment of Glanzmann thrombocythemia, we are aiming 2 things, and we have to keep that in mind in any bleeding tendency. To treat a bleeding episode now, or to prevent bleeding during any invasive or surgical or delivery, any procedure. We have to prevent bleeding, and we have to get that safely. So what if this patient is going to give birth? What if this patient is in need of surgery? This is the situation of whoever invasive will going to interfere. Platelet transfusion is a very good choice, but it has hazards. With time, the patient will develop antiplatelet antibody, what we call alloimmunization. Infection is very common. I have seen patients with bleeding tendencies when I was a student in the late 80s with HIV complicating coagulation factor abnormality and platelet defect. I have seen 3 cases like that. Immunological, as I said, reaction could be there. And we know that the platelet stays very functioning in the circulation 5 to 7 days in the peak, and they are doing the function up to 10, 12 days, and after that, everything will vanish. It was like that till the start of the new millennium, when by chance, they discovered experimentally that adding activated factor 10 to patients, to the blood of the patient with Glanzmann thrombocythemia, it will enhance production of platelet. And this was the first time to realize that and to recognize that reaction in a patient with marked platelet defect. Then this was confirmed by the next year that there is a great difference in platelet aggregation when we use activated factor 7 or recombinant factor 7. In July 2014, this drug have been approved by the FDA to be used in cases with Glanzmann thrombocythemia and as a replacement of other coagulation factor defect, because it could be a life-threatening condition, not only for gynecological patients. It have been used in war scene for severely injured patients. They injected them to prevent massive bleeding and to prevent their death till they become triaged to someplace else. The mechanism of action is variable. The recombinant factor 7 enhance local tissue factor dependent thrombin generation. It potentiates platelet activation. It enhances receptor independent platelet aggregation. It binds platelets by another mechanism many coagulation factor enhancing fibrin formation and increase local fibrin deposition. And these are the stages we just mentioned with the end of formation of a competent platelet aggregate, then thrombus preventing bleeding. What are the doses? The usual common dose or recommended dose is 90 microgram per kg. I usually use between 75 to 90 in mild cases, and I might go for higher. This dose should be given 1.5 and 2.5 hours interval. A third dose could be needed to confirm prevention of bleeding. What about the response rate? It's always, in any situation, more than 94% or 93%, and it could reach up to 100% in some cases. This is a wonderful paper published on 2017, describing the condition of more than 1,200 patients with Glanzmann thrombocythemia, those who went into surgical intervention. Success rate was ranging from 92.7% when we use recombinant factor 7 alone, up to 100% when we use platelet-specific antibody in combination in cases of having platelet-specific antibody against these receptors. In surgical procedure, again, we are having the same success rate, about 98%. So we can use them in surgical condition. This in surgical condition, we can use it in even heavy menstruation. And a very nice protocol have been adopted by the Gulf Society of Bleeding Tendency, particularly in pediatrics. They give hormonal therapy, and before the suspected time of menstruation, they stop the hormone, they start the tranexamic acid, and after 3 to 5 days, they stop tranexamic acid and they restart hormone again. And they observe the patient. If she has bleeding, everything will be fine like that. But if she starts to bleed, they can give her fractionated dose, small doses of recombinant factor 7 to prevent bleeding, and this could be repeated monthly. They can afford that because factor 7 is very expensive, but unfortunately, we cannot apply that for our patient in Egypt. If we can do that, we could save a lot of patients, and we could prevent a lot of severe iron deficiency anemia. I know we are in an OBGYN conference, but Glanzmann thrombocythemia is not only a ladies' disease. Ladies present more frequently because they have monthly bleeding. But gentlemen, here we are having couple of brothers are having severe Glanzmann thrombocythemia. They are brothers, their parents are first-degree cousins. In spite of that, in the best hand, in the best centers in the world, still Glanzmann thrombasthenia is missed and diagnosed as ITP or von Willebrand disease up to 20-25% of cases. So the peril of that is, let us talk to each other, let us communicate, and let us properly diagnose our patient. Just one slide or two, we have something called acquired Glanzmann thrombasthenia, when we have antibodies against these receptors, and these have been mostly discovered in cases of autoimmune disease and lymphoproliferative malignancies. And even Glanzmann thrombasthenia have been reported in cases of ITP, and in those cases, bleeding is more. My last thing, which I'm going to point, is what is called recessively inherited coagulation disorders. This is one of example of falling of empires because of a hematological disease. This is Alexis, son of the last crown prince of the Romanov Empire in Russia, who has had severe hemophilia. And because of this very vicious person, Rasputin, who have a great impact in hatred between the population and this family. And this recessively inherited coagulation disorder, in contrary to hemophilia A and B, they are not X-linked diseases, they are autosomal recessive disorders. This is the list of these autosomal recessive disorders, and we know that factor VII deficiency is the most frequent of them. Not only like that, we could identify exactly where is the gene of each coagulation factor defect of these, and what is the clinical manifestation of each of them. I will focus بعد إذن حضراتكم على factor 13 هنا. عيانة الفactor 13 deficiency, the presentation of her could be only recurrent episodes of miscarriage. واحنا نقعد ندور على anti phospholipid أو ندور على anti cardiolipin أو ندور على factor 5 Leiden mutation، والحدوته كلها ان العيانه عندها mutation في factor 13، والعيانين دول ما بيبقاش عندهم نهائي اي تشينج في الكواجيليشن بروفايل بتاعها. So when we have factor 7 deficiency, الحل, the answer is replace what is deficient. It's as simple as that. So these are, as I said, the mutation in chromosome number 13. What's really interesting, that bleeding in factor 7 deficiency is more similar to bleeding in platelet abnormality. We don't have here muscle or joint bleeding like other coagulation factors. عشان كده الصورة بتبقى a little bit foggy more واحنا بنتعامل مع هذا الفactor deficiency. We classify them, factor 7 deficiency, into type 3 10% 10 ل 20 و20 ل 50. Again, the diagnosis هنا is a little bit different. We have prolonged prothrombin time, لأنه في common pathway. We have reduced factor 7 level in the serum, and we have elevated INR. So we do have a coagulation factor defect or a coagulation abnormality. Of course, we can give fresh frozen plasma, cryoprecipitate, prothrombin complex, plasma-derived factor 7, but still recombinant factor 7 will avoid all the plasma complications, and it will replace what we are missing in those patients. We can give, again, as I said, tranexamic acid, fibrin glue locally. We can give hormones, but it have been approved as a treatment for factor 7 deficiency. I have a couple of cases who went, one of them had a gangrenous gallbladder, and the other one, again, as a daughter of two first-degree cousin parents with factor 7 deficiency when she was in labor, and we give her recombinant factor 7. According to this steer study, it was the cause again of FDA approval for recombinant factor 7 and factor 7 deficiency. When they give it on demand to prevent bleeding prior to menstruation, they give success rate of 96%. In surgery, it gives success rate of 94%. The only side effect, 3 thrombotic episodes, 1 inhibitor have been recorded after multiple injection of the factor, and few additional minimal grade 1, 2 adverse effects. With that, I finish my presentation, and thank you.